Okay, welcome everybody to Department of Medicine, Grand Rounds. I'm going to introduce the chief of the endocrine division, Dr. Christoph Buettner, who's going to introduce our speakers today. Dr. Buettner?
Thank you, David. So today's session is, I believe, incredibly important, not just because my grandmother died after an osteoporotic hip fracture a few days later, but because osteoporosis is a condition that's vastly underdiagnosed, and because there are lots of powerful drugs out there that we can use to treat this condition. So it's an interesting way to have organized these grand rounds that David, Julia Grimes, and Anupa Sharma put together. So Dr. Grimes is an associate professor of medicine in the Division of General Internal Medicine here at Robert Wood Johnson. She graduated from Rutgers and then UMDNJ School of Osteopathic Medicine. And during her residency at UMDNJ Robert Wood Johnson, she completed an NRSA, postdoctoral fellowship in health service research, and obtained her MPH in epidemiology before she joined the faculty in 2002. Her clinical interests include bone health, outcomes in hip fractures, and women health. So my grandmother would have benefited from your presence. Dr. Sharma is an assistant professor in our endocrine division here at Robert Wood Johnson. She graduated from Barnett College and then New York Tech College of Osteopathic Medicine, followed by an internal medicine residency and endocrine fellowship here at Robert Wood Johnson Medical School. She's currently one of the co-directors of the Rutgers Osteoporosis Center. Both Dr. Grimes and Sharma are members of International Society of Clinical Densitometry and are certified clinical densitometrists. So we are lucky to have them both here today. Our grand rounds will be slightly different, as I mentioned earlier, with two speakers who will be offering slightly different perspectives on a clinical question that many of us face as a way of teaching us. And hopefully this provides a good model for future grand rounds as David is planning to. With that, Julia and Anupa, take it away.
Great. Thank you so much, Dr. Buettner and Dr. Cohen. I would like to welcome you to Grand Rounds. Today, we will present a review of the osteoporosis guidelines from the perspective of an internist versus an endocrinologist. This Grand Rounds will be in a different format, like Dr. Buettner said, that you are used to, and it will be more interactive. As a bonus, please email us at the end of the presentation with one fact that you learned during the lecture for an opportunity to win a free body composition. If you have any questions along the way, please feel free to send a message in the chat box. So my name is Dr. Anupa Sharma, and I will be presenting with Dr. Julia Grimes. Like Dr. Buettner said, I currently work as a board certified endocrinologist, and Dr. Grimes works as a board certified internist here at Rutgers Robert Wood Johnson Medical School. We are both certified clinical densitometrists, which is an international designation that recognizes clinicians that maintain standards of excellence to interpret DEXA scans. So today, the objectives. We hope you will leave this lecture having learned how to define osteoporosis and discuss clinical utility of DEXA, define new risk stratification and their respective treatment approaches, as well as review the current monitoring recommendations. So what is osteoporosis? Osteoporosis is a silent disease until it is complicated by fractures. These fractures that may occur following minimal trauma or even in some cases, no trauma. It is characterized by low bone mass, deterioration of bone tissue, disruption of bone architecture, and compromised bone strength. The figures on the right show the changes within the calcaneus bone as a consequence of bone loss. As seen in the osteoporotic bone figure, individual trabecular plates of bone are lost, leaving an architecturally weakened structure with reduced mass. I like to make the analogy to a sponge here. On the left side is a new sponge, and on the right, it's after many weeks of use and it's lost its structural integrity. So the process of bone remodeling may be considered a necessary maintenance program in which older bone is removed and it is replaced by newer bone. Remodeling serves to remove dead osteocytes, maintain adequate nutrient supply, repair damage, and thus prevents fracture. Osteoclasts and osteoblasts, which I hope you can see my pointer. So osteoclasts and osteoblasts belong to this whole structure here, which is known as the bone remodeling unit. In a healthy human adult, 3 to 4 million bone remodeling units are initiated per year, and approximately 1 million are actually operating at any one moment. Each bone remodeling unit is composed of osteoclasts in the front, as seen here, and then osteoblasts in the back. So each unit begins at a particular place and time and advances toward an area needing replacement, as seen in this full cycle above. The stages of the remodeling cycle include resorption, reversal, and formation. These all take different times. So resorption continues approximately for 2 weeks and is when there's an introduction of the osteoclast. The reversal phase may last up to, anywhere upwards of 4 to 5 weeks and includes the introduction of the osteoblast precursor, while formation continues for up to 4 months until the new bone structural unit is fully formed. So a little bit about the demographics of osteoporosis. So the National Osteoporosis Foundation estimates that 10.2 million Americans have osteoporosis and 43.4 million have low bone mass, which is also referred to as osteopenia. More than 2 million osteoporotic related fractures occur annually in the United States, and more than 70% of these actually occur in women. And a very startling statistic is less than 1 in 4 women aged 67 years or older with an osteoporotic related fracture gets their bone density measured or begins osteoporosis treatment. So what does that translate to? It translates to a very large cost burden. They estimate that the disease burden is roughly $20 billion a year. So here's a figure that demonstrates the incidence of osteoporosis versus other disease. Worldwide, an osteoporotic fracture occurs every 3 seconds. So by the end of this lecture, 1,200 fractures have occurred. So just let that sink in. 1 in 2 women and 1 in 4 men over the age of 50 will sustain an osteoporotic fracture in their lifetime. In the United States alone, 1.5 million new osteoporotic fractures occur annually, with the most common type being vertebral fractures. Current estimates place that this cost is about $20 billion. So let's compare that to other disease processes. For comparison, breast cancer is 13 billion with an incidence of 184,000, while heart disease is approximately 19 billion. So theoretically, osteoporosis is preventable and treatable. So there is opportunity to reduce this large cost burden.
So I'm going to be introducing and leading the polling questions. Dr. Sharma will be behind the scenes navigating your responses. So as such, there may be a delay between the polling results and the subsequent slide. So our first question is, what is the gold standard for diagnosing osteoporosis? And that would be A, spine x-ray, B, laboratory assessment, C, DEXA scan, D, presence of wrist fracture, and E, hip x-ray. So please, if you wouldn't mind just entering your answers, please. Okay, it looks like the vast majority in the audience seems to recognize that the gold standard is the DEXA scan. So that's terrific. I'm glad that many of us seem to be aware of that. So let's move on and talk about the utility, the clinical utility of the DEXA scan. So the DEXA is a dual energy X-ray absorbentometry, which is used to diagnose osteoporosis or low bone density. It also helps to estimate future risk of fracture and monitor change over time. The diagnosis is the rationale is the T-score of these particular skeletal sites are good predictors of future fracture risk. And then the other key component is the monitoring component, and that requires knowledge of precision. And just be aware that our facility documents the LSC, which stands for the least significant change, and that reflects the in vivo precision of our machine, which is really important when you're monitoring subsequent measurements across the board. So the next slide is going to go over how does a DEXA actually work. So a DEXA has this concept of the dual energy absorptiometry. And what happens in this is the patient, which is in this particular slide looks like an olive, lies still. And what happened is there's a movable C-arm with radiographic tubes with a detector that transverses the patient. The patient is lying still. And what happens is that there are two different energy levels, hence the term dual energy. And a collimator below the table gathers the scatters from the photon and then directs them towards the area of interest. The patient again lies still throughout this. And patients and people always ask about radiation exposure associated with this. And this is comparable to traveling across the United States air travel from New York City to California. And one DEXA scan is roughly equivalent to about a third of a routine chest x-ray. So minimal x-ray exposure. So what's most exciting, and probably one of the major reasons is prompting this grand rounds, is that we're exceedingly excited about the fact that we're going to get GE's iDEXA second generation, and it's coming to Robert Wood Johnson. So there's our address that you notice at the bottom. And what's really exciting about this new machine is that it can scan up to 450 pounds in an individual. It also can determine body fat, body composition, whole body, bone mineral density. Anupa, I can't forward it. Are you able to forward it?
Yep, sorry. It's a little delayed.
Gotcha, no worries. And the key component to this, and some of you may be aware of it, is that in addition, it actually isolates visceral fat, which is commanding a lot of attention in the clinical world because this is thought to be more bioactive fat, and it's associated with metabolic and cardiovascular diseases. It's associated with dementia. And if you've been paying attention to recent research with COVID, severity of COVID-19 is associated with specific incidences of high visceral fat. So this is really exciting that we're going to have this opportunity. And if you notice in the bottom right-hand corner, the quality of the images allows you to better delineate bone changes. It also captures a lot of lean body mass as well, which is important for some patients in terms of weight loss or weight gain. So we're excessively excited about this. It also can be involved with scanning children, looking at failure to thrive and other components if you're trying to understand growth patterns. And the other most exciting thing is our center has recently been designated from the International Society of Clinical Densitometry for accreditation. And currently we are the only academic facility in New Jersey that has this accreditation. So who to screen? So this is again, maybe information that you already know, but so patients age 50 to 64 with one risk factor, and the list is listed below. These are individuals that you want to consider screening with a DEXA. So if they have a fragility fracture, a parental history of fracture, smoking or alcohol use, low body mass, a really important thing that people forget about is a height loss greater than 2 inches. So there's another really important thing to think about. Corticosteroid treatments and certain disorders such as rheumatoid arthritis, hypothyroidism, hyperparathyroidism. Also, patients under the age of 50, patients who are about to embark on long-term corticosteroid use, transplant patients, women that have undergone early menopause, and or males with hypogonadism or taking androgen deprivation therapy. And of course, many of you already know this, all women over the age of 65, regardless of risk factors, needs a baseline screening DEXA. And to reiterate what Dr. Sharma talked about, 1 in 4 men and 1 in 2 women can expect an osteoporotic related fracture in their lifetime. So the next slide is going to talk about diagnosis of osteoporosis. And again, it might be review for some of the audience, but remember that T-scores less than T-score less than negative 2.5 in the lumbar and femoral neck area is considered osteoporotic. Low trauma spine or hip fractures, regardless of the bone mineral density score, is considered osteoporotic. The T-scores, now T-scores that would normally be in the osteopenia range or the low bone density, -1 to -2.5, and a fragility fracture are now considered diagnosis of osteoporosis. And again, with these T-scores, -1 to -2.5, and a high frax, which we'll talk about shortly, are also considered diagnosis of osteoporosis. Anupa, I just want to share with you, the polling still continues on my screen, so I'm not able to, okay, never mind, I got it. All right, so our next question, ladies and gentlemen, which component is not part of the frax? So that would be either age, family history of fracture, current smoker, serum calcium level, or the presence of rheumatoid arthritis. So if you guys wouldn't mind registering what is not part of the frax, and we'll share those results shortly. Thank you, guys. I appreciate your participation. I know it's—
There's still voting going on, so I'm letting it go for a few extra minutes.
Yeah, no, it's great.
Seconds.
Okay, so we're going to share the results, and the vast majority got the right answer, which is serum calcium levels are not part of the frax. A handful of you weren't sure about the presence of rheumatoid arthritis, and that actually is a component associated with the frax assessment, and then family history is as well. So, so let's go and look at the next slide, which will reveal the fracture risk assessment tool. Now it's kind of busy a little bit, but this was actually done internationally, and many parts of the world don't have access to a DEXA machine. And so these are key components for them to assess risk fracture. And this is the concept of developing a risk fracture, or a fracture in the next 10 years. So age, sex, height and weight, family history of a hip fracture, personal history of a fragility fracture, and the idea of steroid use, rheumatoid arthritis, smoking, alcohol, which here is considered 2 or more units daily, and secondary osteoporosis. And then Anupa's going to forward. Yeah, so this is a really nice calculation tool that is online. You can put it on an app, you can put it on your iPhone. And what here you're supposed to calculate, enter in these factors, and it calculates your risk. Now this is, of course, because it's international, it deals with kilograms and centimeters, but there's an application within this app that you can enter weight, pounds and inches, and it will convert it for you. And the other key component is to make sure that you register under the United States, because the results are slightly different in different countries. They have different thresholds for active treatment. And so what's nice is at the bottom, it describes your risk of developing in the next 10 years, a major osteoporotic fracture and or a hip fracture. And in the United States, the cutoff is 3% for hip fractures and 20% for major osteoporotic.
So shifting gears, we will present a case and we will evaluate the different societies' viewpoints regarding choosing and monitoring treatment. So Mrs. L. So Mrs. L is a 72-year-old female with a past medical history of an adrenal incidentaloma and low bone density. She fractured her wrist in 2010 after a traumatic fall. She was first noted to have osteopenia in 2016, at which time she started treatment with calcium and vitamin D supplementation. In 2020, repeat bone density demonstrated osteoporosis. Her 10-year risk for hip fracture using the frax tool was 5.4%, and 10-year risk for any major osteoporotic fracture was 22%. Her medical history includes hypertension, diabetes type 2, hyperlipidemia, and a non-functional adrenal nodule. There is no known family history of osteoporosis. Current medications include amlodipine, benazepril, rosuvastatin, glucophage, vitamin D, and calcium supplementation. She is a retired administrator. She is a widower, has 2 adult children, but lives alone. She enjoys walking 3 miles a day, has never smoked, and does not drink alcohol. So as you can see here, this is a schematic, a chart that demonstrates the BMD and T-score from 2016 to 2020. So comparing 2016 to 2020, there was a decline in the bone mineral density as demonstrated in the values of the BMD itself and T-score. A more negative T-score is indicative of worsening bone loss. So please focus your attention to here, the T-score on the spine in 2020 as being minus 3.5 and the high fracture risk of 5.4% at the hip. Of note, when evaluating 2 or more DEXAs, you must ensure the machinery and the technology used was the same. Since the technology between these 2 DEXA scans was different, as notated here with Hologic and versus GE Lunar, the BMD values itself are not comparable. So it's essentially like you're comparing apples and oranges. So to structure our debate, we will discuss the following questions to consider when applying key internal medicine and endocrinology guidelines to clinical practice, and particularly our patient. So the first question, what treatment would you initiate in this patient and why? How would you monitor a patient receiving treatment and when? And what is the optimal duration of therapy?
So the next question we're going to ask you is, what treatment would you initiate in this patient? So A, zoledronic acid reclass, that would be an IV infusion once a year. Denosumab, Prolia, sub-Q injection every 6 months. Teriparatide, Forteo, sub-Q daily. Alendronate, Fosamax, which is oral weekly preparation. And I'm going to try my best here. Romosozumab, which is a sub-Q monthly injection. So thank you for registering your choices here.
Gonna see if we get a few more.
Okay. All right, so nice. So about 84% of you suggested that the alendronate Fosamax oral weekly was your choice. A handful picked the reclass IV infusion, and one of you chose the last choice. So I'm going to take this opportunity to discuss the ACP guidelines that were issued in 2017. And here the suggestion or the recommendations was for pharmacological treatment with alendronate, resigenate, zoledronic acid, denosumab to reduce hip and vertebral fractures. And these are patients with known osteoporosis, and the evidence here was strong. I'm sorry, the recommendations were strong and it was a high quality evidence. And what was unique and somewhat controversial is they also recommended against the use of menopausal estrogen therapy, plus or minus progesterone therapy, and raloxifene for the treatment of osteoporosis in women. And this differed from the ACP guidelines that were issued nearly a decade prior. And this was considered a strong recommendation and moderate quality evidence. And the studies here focused, the rationale behind this was that the studies done in 2008 really focused on postmenopausal women who may have also had just low bone density, as opposed to the newer data that specifically just focused on women with established osteoporosis. So a few moments here, we're going to take a look at the anti-resorptive therapies used to treat and prevent osteoporosis. So the bisphosphonates, which many of you are aware of, and here's a handful of them listed here, the oral administration, some that can be given IV in addition to their dosage. The rank ligand antibodies, denosumab is the other class of agents that can be used, and then selective estrogen receptor modulators and hormone replacement therapy. And specifically here, we're going to talk about oral estrogens. We're not talking about topical or transdermal preparations. So bisphosphonates, as many of you are aware, they're considered sort of first-line treatment. The mechanism of actions, if you can kind of remember that really nice schematic that Dr. Sharma talked about earlier in the lecture, this is targeting the osteoclastic activity and shortening their lifespan. These are excessively effective in reducing vertebral and non-vertebral fractures, including hip. There's about a 50% reduction. Some are a little more potent than others. I will pay attention to the fact that zoledronic acid reclass is excessively potent, specifically in the first year. So if you really need to get a rapid response, it's about a 70% reduction in vertebral fractures in the first year. But the caveat with all this is you have to think about some of the pros about this treatment is that there's limited GI absorption. Only about 5% gets absorbed, 95% doesn't. It has an excessively long half-life as it gets embedded into the bone. And then the con, of course, is that it must be taken on an empty stomach in the upright position for 30 minutes. But because of these pharmacokinetics, this actually has brought to fruition this idea of a drug holiday, meaning that you would stop either oral ingestion or IV infusion of these medications, knowing that their effects on the bone will continue beyond it. But you can never talk about bisphosphonates without mentioning the side effects. And this, for whatever reason, gets a lot of play. And I just want to always put it in context. So the osteonecrosis of the jaw, and I'm not minimizing it, is an ugly looking, the pictures are usually very distracting, but it is extremely rare. And to give you some context, they happen in about 0.1% in 10 years of use. If you want to compare this to a fatal motor vehicle accident, that's 0.11% in 10 years, and atypical femur fractures, 0.5% in 10 years. So just to give you a frame of reference. Rank ligand antibodies, denosumab, the mechanism of actions here, again, we're targeting the osteoclast, but it's an antibody that's targeting one of the factors necessary for osteoclast maturation. They have a similar effect in terms of reducing vertebral and non-vertebral fractures. But what's interesting here is the effectiveness is limited to 6 months. And so it needs to be redosed. And so hence the twice yearly injection. Side effects, hypokalemia, not that common, 2% cases, some cellulitis. And then the osteonecrosis of the jaw, some people think it's less likely. Most people argue that it's just less exposure, meaning there's less prevalence data on this. One study in 2017 indicated that there was about 5.2 cases in a 10,000 person year use. The pros and cons of this particular treatment is its duration of action is limited, and sometimes this is actually beneficial for certain populations. For example, women in their reproductive years, or if somebody has a known exposure that was potentially osteotoxic, this might be a treatment for protection. The cons are that there's rebound vertebral fractures with abrupt discontinuation. And I think that doesn't get enough press or play, that people recognize that you really need to think about. It's like the return on investment goes away once it's out of the system. And here's a handful way to remember how to remember the generic name denosumab. Den is from density, OS is from osteo, U is U for us humans, and mob because it's a monoclonal antibody. Last thing, I'm not going to spend a whole lot of time on this, but just as a reminder that hormones, SERMs, and hormone therapy, there are some selective cases where risk-benefit favors limited exposure to confer bone protection and treatment. And this is raloxifene 60 milligrams daily, which has some additive benefits potentially for breast cancer reduction. And then oral estrogen therapy, again, a balanced individual risk with these individual patients. So back to our patient, myself and the ACP, based on Mrs. L's presentation, we would recommend initiating treatment with either a bisphosphonate therapy or rank ligand monoclonal antibody.
So I'm going to take a different viewpoint on this. So while bisphosphonates are typically first line, there can be negative consequences if not prescribed correctly. Thus, I'll present the second approach to consider when determining the best treatment option. So I'd like to bring your attention towards the bottom of the table to the very high fracture column. When starting treatment, it is appropriate to stratify patients by their level of risk. Some who are at very high fracture risk may require more aggressive treatment to achieve an acceptable level of fracture risk. There is evidence supporting superiority of anabolic agents over anti-resorptive agents in reducing vertebral fracture risk in very high risk patients. So in 2020, ACE redefined the very high fracture risk group. It is now more expansive. It includes patients with a recent fracture within the past 12 months, those who have fractures while on approved osteoporotic therapy, those with multiple fractures, fractures while on drugs causing skeletal harm, such as long-term glucocorticoids, those with very low T-scores, less than 3, a high risk of falls or frequent history of falls, and those with a very high fracture probability by FRAX, which they define as greater than 30% at the major osteoporotic site, or any hip fracture greater than 4.5%. So in 2020, ACE recommended that injectable agents such as abaloparatide, denosumab, romosozumab, teriparatide, or zoledronic acid can be considered as initial therapy for those who are very high risk for fracture, those who have GI problems and may not tolerate or absorb oral medications, and those who have trouble remembering to take oral medications or coordinating oral bisphosphonate with other oral medications or daily routines. So it seems intuitive that therapies that stimulate bone formation such as anabolic agents and restore the bone microarchitecture would have greater improvements on the bone mineral density, making them superior options. So here I have a schematic comparing teriparatide and abaloparatide. So teriparatide is a recombinant human parathyroid hormone, and it comprises the first 34 amino acids of the N-terminal end of parathyroid hormone. Conversely, abaloparatide is a 34 amino acid synthetic analog of PTHRP, and it is identical to PTHRP except at the last 2 amino acids, 23 and 24. So teriparatide and abaloparatide actually bind to the receptors at the PTH1R. So on the left-hand side of this schematic, focus your attention here. So teriparatide activates parathyroid hormone receptor type 1 in the R' conformation, and it results in an intracellular release of cyclical AMP. Conversely, on the right-hand side, abaloparatide activates the RG conformation, and that results in a more transient cyclical AMP release. So selective binding of this RG conformation confers a more transient response and favors bone formation. So the pivotal study that demonstrated the success of abaloparatide was published in JAMA in 2016. It evaluated 2,400 approximately postmenopausal women, and it randomized them to either blinded subcutaneous abaloparatide or placebo versus open label teriparatide for 18 months. As you can see here, in the lumbar spine, the BMD increases were seen with both drugs versus the placebo, but greatest in the abaloparatide group. Here, the BMD increases from baseline to 6 months in the abaloparatide treated group were greater than those in the teriparatide group at both the total hip and the femoral neck. The abaloparatide BMD hip increases were much more rapid and occurred with greater magnitude, first occurring at 6 months. So some attribute this to the immediate transient increase in the cyclical AMP that's seen with the binding with abaloparatide. So teriparatide has been available worldwide since 2002. Abaloparatide has been available since 2017. They are both daily injections, both very well tolerated drugs with minimal side effects, but unfortunately they are very expensive. You know, side effects commonly reported include nausea, orthostatic hypotension, and leg cramps. These agents should not be used for greater than 2 years. Both abaloparatide and teriparatide have black box warnings because of the occurrence of osteosarcomas seen in rats when given very high doses. The doses were given at 3 times what humans receive. So never been seen in humans, though. So contraindication for use is patients that are at an increased risk of osteosarcoma, such as those that have Paget's disease, open epiphysis, a history of irradiation involving the skeleton, unexplained elevation of alkaline phosphatase levels, or patients with primary or any form of secondary untreated unresolved hyperparathyroidism. A key note between the differences between the two drugs is that abaloparatide does not require refrigeration, so it's a little bit easier for the patient to handle. So treatment post-anabolic therapy. When treatment with an anabolic therapy stops, bone density declines quickly during the following year. So the use of bisphosphonates or denosumab after anabolic therapy prevents this loss and may result in further increases in BMD. Excuse me. One study that demonstrates the importance of this was the Active Extend, which is an extension of the previous trial I just presented. So those patients that received abaloparatide versus placebo were actually eligible to receive 24 months of alendronate. So during the full 43-month treatment period, 0.9% of the women on the abaloparatide alendronate group versus 5.6% of those in the placebo versus alendronate group experienced a new radiographic vertebral fracture. So it was less. There is no apparent rationale for a washout period or drug holiday between the ending of the anabolic therapy and the initiation of an anti-resorptive. So just to summarize, we've now reviewed the anti-resorptives as well as the anabolic therapies, but there's a new drug on the block, romosozumab. So a little bit about this drug. So sclerostin, it's encoded by the SOS gene found on osteocytes. How does sclerostin work? So I want to bring your attention to the schematic on the right. So sclerostin typically binds and inactivates LRP5 and 6. That ultimately inhibits the Wnt pathway, which ultimately results in bone loss. Romosozumab is a monoclonal anti-sclerostin antibody. So what happens here is that when the antibody binds to sclerostin, seen here, sclerostin cannot bind to the LRP5 and 6 to inactivate the pathway. So Wnt is actually able to activate the pathway and ultimately results in bone formation. So use of romosozumab, it's a sub-Q injection that's given monthly for 12 months. Its indication for use include patients that are very high risk for fracture, previously treated patients with teriparatide or abaloparatide that have completed the 2-year course, or in those patients in whom anabolic therapy would be ideal, but they've had a history of radiation exposure, which limits its use. However, you may want to avoid this drug in patients with a recent, which they define within the past 1 year, history of heart attack or stroke. So the above table 2 is seen in the pivotal trial evaluating romosozumab versus alendronate and was published in the New England Journal of Medicine in 2017. So during year 1, which is the first 2 columns here, positively adjudicated serious cardiovascular events were observed more often with the romosozumab group at 2.5 versus 1.9%. However, when this analysis was extended to 24 months, seen in this column, the incidence of cardiovascular events was relatively similar at 6.5 versus 6.1%. Additionally, in the initial phase 3 trial that earned romosozumab the agreements, the safety profile of romosozumab, it did not show this increased incidence of cardiovascular events. However, because of this table specifically, a black box warning was given to romosozumab. So it should not be used in patients who are at high risk for cardiovascular disease or those who have had a recent MI or stroke. So back to our patient, myself and ACE would recommend the use of an anabolic therapy based on the patient's elevated fracs and her very low T-score of -3.4. However, Mrs. L actually opted to take zoledronic acid IV.
So we're going to go back to another polling question. And the question here is, would you monitor a patient receiving treatment with a DEXA scan? So please enter in your responses, a simple yes or no. That would be terrific. Since we all know it's the gold standard, would you monitor All right. So as long as we get 50%, I want to move. Yeah, so the vast majority, about 90% of you indicate that you would go ahead and monitor a patient with a DEXA scan. And so the next question is to determine what frequency. So would you do it yearly, every 1 to 2 years, every 3 to 5 years, 5 years, or when clinically indicated? So please feel free to enter in your responses, and you can understand that there's a range here, and this is to cultivate debate and questions about the frequency. One thing about physicians, right? You can never always have the same answer, and that's the beauty of it. All right, are we getting close to 50%? Yeah, okay, so the best, about 2/3 of you indicate that you would want to get a DEXA scan every 1 to 2 years. About 10% or so thought yearly, and another 20% thought every 3 to 5 years. Let me just stop sharing. And so so I'm going to get rid of this, sorry. So monitoring bone density treatment, bone density while on treatment, there are several published guidelines for monitoring this. All recommend using DEXA as a way to monitor. However, there's no consensus on the optimal frequency of monitoring across varying societies. So not surprisingly, I'm going to discuss the ACP guidelines that were issued again in 2017, and they are pretty stark. They suggest that during the 5-year pharmacological treatment that there's no indication to monitor. This is a weak recommendation based on low quality evidence. But part of this rationale was this moderate quality of evidence that showed that women who were on anti-resorptive treatment, regardless of whether there was an increase in bone mineral density or bone mineral density decrease, they had the clinical phenomena of reduced fracture with treatment. So their concept was, why bother doing the monitoring? And embedded in some of this decision-making was there was some evidence of women who had normal bone mineral density that most of them didn't progress to osteoporosis within 15 years. So the rationale was, why bother monitoring?
So to present a contrasting view, I believe it is actually important to monitor treatment for the following reasons. Number one, patients may actually lose BMD on treatment and might do better on a more potent drug. Bone loss, despite treatment, may indicate a secondary undiagnosed cause. And lastly, it can increase adherence. So it's important that the frequency of BMD reevaluation needs to be individualized. So just to review the 2020 ACE guidelines. So for patients on treatment or with a baseline evaluation indicating treatment, BMD testing should be considered every 1 to 2 years is what they state. This applies to all postmenopausal women. Generally, menopausal bone loss occurs at a rate between 0.5 to 5%. It begins 3 to 5 years before the last menstrual period and continues for 3 to 5 years after the cessation of menses, and on average occurs at 1 to 2% per year. This also recommends that screening should be done more frequently to identify those at risk for more rapid bone loss, which they define as being more than 3 to 5% per year. And that includes patients that are stopping hormone replacement therapy, those on glucocorticoids, and those who use aromatase inhibitor therapy. So here we summarize the 4 major organizations and their recommendations on monitoring. Essentially, the top 3, the International Society of Clinical Densitometry, National Osteoporosis Foundation, and ACE, are in line with each other. They recommend that you monitor roughly 1 to 2 years after the initiation of therapy or change of therapy, whereas ACP recommends against monitoring while on therapy. So while the basis of ACE's recommendation is that the several studies indicated that women treated with anti-resorptives had fewer fractures despite no change in the BMD, I worry that if these guidelines are utilized, higher risk patients or missed secondary causes will result in worsening osteoporosis, and this ultimately worsens the cost burden of the disease. So back to our patient. ACP would recommend against monitoring if on treatment, since it will not change the outcome. Dr. Grimes and myself, in line with ACE, would recommend repeat DEXA after 1 year since she is very high risk and could possibly benefit from a more potent drug.
So again, another polling question, how long to recommend anti-resorptive treatments? So would you do it for 1 year, 3 years, 5 years, indefinitely? And I don't know. So if you wouldn't mind putting in your responses, and I know we're getting close to the end of the hour, so I'll try to gather up the information. So it looks like, yeah, so choice C seems to be the most common response, and that's about 50% of you think every 5 years. A handful did every 3 years. Indefinitely was a few, and some said, I don't know. And I appreciate your honesty because it's not always so transparent. So the goal of a successful treatment is, this is our big picture, is we're trying to prevent fractures, but no treatment can eliminate the risk of fracture. The desired outcome is a higher T-score, which means less negative, or at the very least stable bone. And I always want to make sure patients recognize that stable bone is a positive effect because the tendency is actually to lose bone over time. And important, as Dr. Sharma had mentioned, a fracture during therapy is not necessarily a treatment failure, but what it may mean is that reconsideration of other risk factors or some occult secondary causes that weren't addressed when treatment was initiated. So again, ACP versus ACE. So ACP recommends clinicians to treat osteoporotic women with pharmacological therapy for 5 years. But again, this is a weak recommendation based on low quality evidence, but embedded in that guidelines did discover or did mention that there are some low quality evidence that show the appropriate duration is clearly uncertain and that there are some high risk patients that may benefit from more than 5 years of treatment.
Contrasting, ACE recommends the differentiation based on their risk score. So if they're low risk, they recommend a drug holiday after 5 years of stability on an oral bisphosphonate versus 3 years on an IV bisphosphonate. In the high risk group, they want you to consider long-term bisphosphonate therapy for up to 10 years on orals versus 6 years on IV bisphosphonates. And the reason for this recommendation is in the FIT trial, which evaluated approximately 6,000 postmenopausal women between the ages of 50 to 81, they were randomly randomized to receive either alendronate or placebo. They went on to evaluate these patients in a trial called FLEX, and they were followed for approximately an additional 4 years. So when they risk stratified the patients and did the evaluations, higher risk women, who were those with a more negative T-score, less than 2.5, who stopped treatment, had nearly twice as many non-vertebral fractures. That was 28 versus 15%. And that suggested that long-term treatment is better for high-risk patients. So back to our patient, she's actually only received 1 dose of IV zoledronic treatment thus far. So in the near future, Dr. Grimes and myself will recommend a duration of treatment based on the follow-up scan and her continued risk profile assessment. We anticipate between 3 to 6 years of treatment with an oral with IV bisphosphonate, but during my continued visits with her, I will continue to discuss with her the consideration of switching to an anabolic therapy based on her very high risk profile. So just to summarize our recommendations. So we'd like you to walk away from this talk and just consider alternate therapies in addition to the anti-resorptive agents, such as anabolic agents in certain high-risk patients. We'd like you to consider monitoring with DEXA scans every 1 to 2 years after initiating treatment to assess for stability, identify treatment failures, and to increase adherence. And once you start treatment, consider a drug holiday between 3 to 5 years. However, remember, certain patients may benefit from prolonged use. If there are any questions along the way, always feel free to refer your patient for consultation. Despite our training backgrounds, over the past 5 years, our treatment strategies actually nicely complement each other and allow us both to provide individualized patient care. So we'd just like to thank you today for listening to our talk and hope you learned how to risk stratify and treat your patients.
And I just wanted to echo that also there's the option of e-consults that are available to you through the EMR. So sometimes if you just want reassurance of some of your decision making, or you're not sure whether it qualifies for consultation, a formal consultation, please feel free to use that option as well. And just as a shout out to other faculty members there, I just want to have you think about, collaborating with colleagues and faculty across divisions and departments. It's really been a really great experience in terms of faculty development. So really think about it, maybe out of your comfort zone, but it's been a really great experience for myself and Dr. Sharma. Yeah. And with that, we'll find out if there's any questions in the chat room, and thank you again.
Thank you very much, Julie and Anupa. This was terrific. So do we have a feel for, based on the guidelines, how many patients do we screen that we should screen, and how many do we not screen that we should screen here at Robert Wood Johnson Medical Center?
So we actually, Julie, if you don't mind, I'll take the lead on this one. So we actually, over the past 3 years, have been had a multidisciplinary approach to actually evaluate this. And we actually have found over the past 3 years, we've actually increased surveillance in patients that needed it over 100%. So we were really missing patients that needed DEXA scans. And I think ultimately that has translated into hopefully improved care and the reduction of fractures in these patients.
I try to also echo, I can't even count how many times we've actually seen a normal DEXA. And so the concern with that is I'm almost always seeing some pathology. And you always think about when the surgeons talks about the appendix, 10% of the time it should be considered normal or thought to be normal. You should have a higher level of suspicion. So thanks for that question. That's really an important component.
I've got a couple of questions here. I'm going to start with a question that I have about racial disparities using the FRAX score. And I guess there's been concern that using the FRAX calculator as is would result in Black women being less likely to be treated than white women counterparts, implying that women in need of treatment are being deprived of it because of their race. Do you guys know any, or can you talk at all about disparities in osteoporosis treatment as a result of use of the FRAX score, or even bone density?
So I'll take that. I mean, so the idea of the FRAX score, those in the audience may or may not know, it is actually separated by race. There is a Hispanic and African-American delineation. And so it is based
on
Asian, sorry, think about that. So it is based on cohorts within that age group, within that delineation. So that's what's available to us right now. But again, as Dr. Cohen presents, you still also want to look at the individual patient, and a lot of these guidelines have their limitations.
There are two questions here in the chat box. One is from Sharma. One, does Medicare approve upfront use of new agents for high-risk patients?
So upfront agents, I've not had full success with that yet, but these guidelines are still relatively new, so it's kind of uncharted water. But that shouldn't deter you from prescribing patients that your patient, that you think your patient rightfully needs, especially because these companies actually do have financial assistance that you can work with them. So if you do have trouble, getting coverage for it, please feel free to send them our way, and we'll do our best to get them.
And then another question is, why have Evista and estrogens fallen off the radar?
Yes, thank you for that question. I honestly think these guidelines have made a big impact and have caused that. And I do think I have a handful of patients that, for whatever reason, will not take a bisphosphonate or denosumab, and to not think about agents that are available to us to prescribe, I think is doing a disservice. So thank you for that question. It's my opinion, my bias is that these guidelines have influenced that decision making.
Yes.
Thanks. Laura asked a question about the risk benefit. Obviously, there may not be randomized controlled trials looking at this, but the risk benefit different for cutaneous estradiol versus oral Premarin.
Yeah, I think my understanding was that the oral
Oral.
had the most notable effect, but I don't think it's been clinically
Studied.
documented.
And then there's a question from Stephen Lieto. Can CAT scans used for other reasons be used to calculate a T-score for use in FRAX calculation?
So, I mean, what's interesting is that radiographic, certainly x-rays, CAT scans to some extent will comment on osteopenia, but you really need to use a DEXA scan to calculate the actual T-scores. And with that T-score, then you enter that into the FRAX. But keep in mind, a lot of third world countries don't have access to a DEXA. So really your best marker in those situations is BMI. So your height and weight are probably the more clinical factors.
Indicators.
Yeah.
Right, but it gets back to Anupa's comment that it's so important to really validate the machine against the normal distribution, etc. So that's the reason for why you can't rely on just a diagnosis of CAT scan, diagnosed osteopenia. Okay, we have 9 a.m. sharp. I want to thank again both the speakers and all of you for attendance. And I hope that the endocrine division with the new DEXA machine will receive lots of new referrals so that we treat this condition that is way too often. And then I hand it over back to David. David, you want to announce next week's speaker?
Oh, so next week, we're gonna have another morbidity and mortality with Pyle and Amy, one of our residents. So we're looking forward to it. Thank you all very much.
Thank you.
Thank you.
And remember to send the email